Hi, Dr. Ajewole.
Hi, Darryl.
Hi, thanks for being part of our conference. Thanks for joining our faculty for our conference. Um, can you tell our audience what you do and where you do it?
Absolutely. Thank you, Darryl. It's a pleasure to have me. My name is Dr. Veronica Ajewole. I am an associate professor of pharmacy practice at Texas Southern University, and I am a clinical pharmacist in oncology at Houston Methodist Hospital. I completed my pharmacy program at Texas Southern University, one of the largest HBCU in the country. And then I went over to Houston Methodist Hospital to complete my residency training in oncology. When I finished my training, I went back to my alma mater as an assistant professor and now as an associate professor. And I established my clinical practice at Houston Methodist Cancer Center, where I see patients that are on oral chemotherapy. So my patient population is pretty diverse, different type of cancers, but like we know, prostate cancer is one of those cancers where oral chemotherapy is being used, as several of the therapies, several of the treatment options are oral chemo. So I do see, a good number of patients that have prostate cancer.
And today we're talking about what we know is an extraordinary crisis in our community, whether you're white or black. The idea that prostate cancer kills black men at 2.4 times the rate as it kills white men. We're come as an organization and a massive support group network. We come to understand that as a consequence of systemic racism in the healthcare system in the United States. What has your research and your understanding around disparity and how Black men face prostate cancer? What has that told you?
Sure. So you are very much right on point, Darryl. It's sad to see the statistics, to see the ratio of that disparity in not just incidence of prostate cancer when you compare, non-Hispanic whites with non-Hispanic Blacks and see the number that it's greater than twice the fold, in incidence for African-American men. And more so when you now look at mortality. So it's like, either way, both in incidence and in mortality, African-American is at a great disadvantage, when it comes to diagnosis, survivorship, treatment opportunities, and everything in between, basically the continuum of care within the prostate cancer spectrum. So this is something that I have come to see myself in my practice, and recently even led me to apply for a grant to the Center for Medicare and Medicaid Services to kind of try to identify what are some of the issues that is making our African-American men develop aggressive type of prostate cancer. So what I'm trying to highlight here is that not only are African-American men diagnosed with prostate cancer, when they are diagnosed with prostate cancer, they are diagnosed with a more aggressive type of prostate cancer, if that makes sense. So because of that, being diagnosed at a later stage, higher PSAs, metastatic diseases that are less responsive to treatment options, makes it an unfavorable situation for African-American men. So one of the things that I'm looking at in that, research that I'm working on with funding from Center for Medicare and Medicaid Services is to try to identify if there is any link between the social determinants of health, and the disparities that we see in the development of aggressive type of prostate cancer for African-American men.
So, social determinants. What does that mean?
Sure. So the social determinants of health, this is just a concept that says our social environment, our inbuilt environment, the environment, the neighborhood that we find ourselves influences the outcomes that we have in life. And these outcomes is not only health-related outcomes, it can be, social, emotional, career options. But in this specific model, looking at how this impacts health outcomes. So here you're looking at, access to food. You're looking at education level within the neighborhood that a patient lives in. Is there pollution in the air? Is there, what type of, schools do the residents in that neighborhood have ready access to? What is the average income ratio of the people in that neighborhood? You're looking at health literacy. How much do they know? What is the basic, health literacy for the people in that environment? Also, you are looking at, educational literacy. What's the average level of education of people within within the environment? So all of that kind of stems up into was considered as a social determinant of health. And specifically for the grant that I'm working on, we're using the LT People 2020, which was, recently updated to be LT People 2030, pretty much setting the goal, this is from a governmental standpoint, setting the goal to develop a healthy environment, LT People, just as the name is, over the next decade. Basically, at the time when I wrote the grant, it was LT People 2020. Now it's LT People 2030. And we are using the pillars of the social determinants of health from the LT People 2020 to build a predictive model to say, okay, is there a link between the social determinants of health based on the zip code, based on the census tract of a patient, and them developing aggressive type prostate cancer?
So the folks watching this are hearing 2030 and saying, like, I don't want to wait that long, and A, and B, I can't wait that long. Most of the folks watching this are already diagnosed and are engaged in trying to determine therapies and treatments and which doctors to see and how to see them and such. Let's talk about your real world experience. Rather than wait till, research is completed and presented. What does racism look like for a Black man in the United States recently diagnosed with prostate cancer?
Yeah, so the racism plays a factor in almost every facet of the continuum of care for cancer. So, and when I speak of continuum of care, I'm talking of prevention, right? Prevention is always key. So can it be prevented? So we're looking at prevention, we're looking at screening. Then even when it comes to diagnosis, treatment, and then patient outcomes. So the idea behind prevention here and screening also is what is the level of health literacy that makes a patient comfortable to say they want to go and get their screening done. If you do a survey for, men 50 years and above, 60 years and above, most of them will bluntly, clearly tell you, no, I don't do no screening for prostate cancer, just because maybe they are not aware of the incidence, they are not aware of the risk, they are not aware of, the need to screen for prostate cancer, or maybe they disbelieve in the system that we have. And unfortunately, when we now look at the underrepresented minority population, access to care is one of the barriers that has been, mentioned over and over again. There's lots of publications about access to care and how that impacts, them getting access to screening for prostate cancer. Because the whole idea here is, okay, if a patient screens early, on time screening, average risk patients start screening at the recommended age, there is a likelihood that if the patient will develop cancer, the cancer could be detected at a lower stage, stage 1, stage 2, where the options could be curative versus now detecting cancer at a late stage where, the options at that point, cure might not be might not be a legitimate option on the table anymore. So definitely the racism factor plays a role. It's more like a ripple effect to where, okay, because a patient is from a Black heritage, African-American descent, happens to be of a lower socioeconomic status, because of that, they don't have that access that, the non-Hispanic white population would have to the healthcare system. So maybe because of lack of insurance, for example, maybe because of transportation, for example, or maybe simply because of health literacy, they are not aware that some of these diseases can actually be screened for, and that there could potentially be preventive measures, up front to prevent a patient from developing a disease. So the ripple effect of racism then leads to that fact that, okay, a patient would not present to the clinic for PSA check, for prostate health check, until the patient becomes symptomatic. Until now, they're having urinary urgency, they are urinating blood, all the symptoms that comes along with prostate cancer diagnosis. So even though it might not be a direct construct, but there is that ripple effect of racism, and it's a big gap of bias that we've seen in our environment in this country, and we are hopeful that decisions will be made, from multifaceted approach to address the bias, to ultimately improve the outcomes of patients with prostate cancer.
Yeah. So the white folks and non-Black folks in our audience are thinking, well, I didn't know about prostate cancer before I was diagnosed. I didn't even know how to pronounce it, let alone where it was in my body. What unique things for Black men are presented vis-a-vis racism that decreases health literacy within the Black community at a rate higher or worse than for any other community in the United States?
Absolutely, Darryl. So, on a regular basis, annual physical is recommended for every patient, right? So everybody's supposed to go in for annual physical check. And the primary care physician is supposed to check, head to toe. And depending on the age of the patient, depending on family history, depending on, any additional factors, at a particular age, 40, 45, 50, somewhere in between, a prostate cancer screening should be discussed with the patient. So that in itself is one of those key places where the discussion should happen. But when we look at the ripple effect of racism, right, like I said, African-American, low economic status, limited access to healthcare, probably does not even see the PCP. Maybe they don't even have a PCP. I know of several of my patients that they don't have a PCP. They never saw the four walls of the clinic until they became symptomatic and they were in the emergency room, and boom, prostate cancer diagnosis. So in the absence of having those core foundational elements that would have built up to saying, okay, prostate health is a priority, you need to start checking. There are ways to test for it. There is a PSA, there is a digital rectal exam that will be performed in the doctor's office, the age, recommendation, and things of that nature. So in the absence of, number one, having that access to seeing a physician in itself, just for routine annual physical checkup, there is already a big limitation on the level of awareness that the patient knows, or what they should have known about prostate cancer. That's one.
Okay. Do you think that, is there any evidence to show that doctors are more reluctant to offer prostate cancer discussion to a Black patient versus any other patient?
Well, that's a great question. And there's been some, publications out there saying that physician-patient relationship. The extent of the physician-patient relationship helps to build trust. And in the absence of having that trust, some of these conversations might not even come up during a physical, during, a visit to the physician, for example. But sometimes even if it comes up, it might just, you go to the doctor, they tell you so many things, right? How many of those things actually sticks in the memory of the patient? Not much. So that's another factor. And then on the part of the physician as a clinician, there is the ethics part of clinical practice that should tell a clinician to share information with the patient regardless of orientation, any form of bias. We should put aside our own implicit bias. We should put aside our own premonition and share information with patient the best way that is possible at the right time, so that when that time comes for a patient to start screening for prostate cancer or any other type of cancer, like any other disease state, they are aware of the fact and they know what to do. There is hesitancy there, definitely, right? Between, physician even discussing it or some patients accepting the procedure to the screen, not just the PSA. The PSA is a blood draw, but then there is a physical examination, which is the digital rectal exam, that sometimes patients find uncomfortable doing. So that's something that some physicians would rather not offer that to their patients. Another thing that I've also found is that there is also that discordant with the gender of the physician. So I found this to be very interesting, when I was having a focus group discussion recently on prostate cancer. And this group of patients, they were telling us that they would rather have a female provider offer and conduct a digital rectal exam as a screening modality for them rather than a male physician. And I'm like, okay, well, I didn't see that as, as a potential barrier, but listening into their conversation, I'm like, okay, I guess this makes sense, because the whole idea, just because of how the screening procedure is, it's not comfortable for everybody. Another aspect of these two is the consistency in the guidelines. And when I speak of the guidelines, you're looking at NCCN, you're looking at, authoritative, the Urology Association and all the societies, right, coming together to issue a consensus to say this is how prostate cancer should be screened. There is really no consensus in between all the 4 or 5 guidelines out there about the time, the age, the how to screen. PSA is generally accepted, but even the PSA, at what threshold do you start making a call to say, okay, there's something bothersome, there's something worrisome, in the screening setting now, not a diagnostic, once everything is already diagnosed is a different discussion, but some of this definitely plays a role and might limit the ability of the physician to say they want to offer the test to the patient or the screening option to the patient.
Yeah, when we did a live conference 2 or 3 years ago, we did what turned out to be the world's first all-female faculty of 15 female doctors, urologists, medical oncologists in prostate cancer, which was very cool. But all of them spoke of how their patients prefer their thinner fingers than the chubby fingers of male physicians.
Exactly. That was what I was told too.
Yeah, thin fingers, which sort of highlights, perhaps urologists should train with their pinkies rather than their index fingers, So the the idea of screening consistency, criteria consistency is obviously a big deal, because when you have a variety of descriptions as to when to draw blood, when to do a DRE, and when to call the urologist if if the elevation occurs, it leaves a lot of leeway for the doctor to play into whatever they may not understand, their inner, prejudices. It would be interesting to see if white doctors are more likely to refer out white patients than black patients to urologists, and at what level of PSA that occurs. At Malecare, we found that men didn't like the idea that white men were told to get screened when they were 45 or 50, but black men or men with history in their family were told at 40. The sense of stigmatization, you're in a different cohort, you're different, a subgroup, and somehow, there's something more wrong or likely to be wrong with you. Even though we're talking about oncology, it doesn't play out when you hear that sort of split in criteria. So as an organization, we just say everyone at the age of 40 should talk to their doctor about prostate cancer. And that just seems like an absolute common sense approach. Removes stigma and gets people to their doctor's offices, even if prostate cancer isn't the primary concern. They get their diabetes handled.
Exactly.
Yeah. Well, yeah. Well, what about in terms of treatment? More black men than white men are initially diagnosed at an advanced stage, as you said earlier. That's certainly true by, I think, like 60% more, something, just totally unacceptable and outrageous. What, as a pharmacist, you get to see people coming in or asking for, oral medications and questions about injectables, and, how you could mix and match drugs with other issues they may have. Should I take Lupron and lisinopril at the same time or something? What do you notice that from your real world experience, any disparities for black men versus white men seeking medications?
Yeah, that's a great question. So what I've noticed is that because of the underlying health literacy issues, it's almost like if you know something, you tend to ask more questions or more relevant questions, I should say, because you have enough basic knowledge about the disease state. So because of the disparity in health literacy between non-Hispanic whites and non-Hispanic blacks, I sometimes have my non-Hispanic white patients come to me with a printout of a clinical trial, believe it or not. That happens to me in clinic. So at that point, when I see a patient coming to me in that light, my discussion level with them is different, because I know, okay, the level of education or literacy of this person is at this level, and that's how I'm going to approach the discussion. Versus maybe a Black patient who does not know so much, and they are pretty vulnerable to the information that you share with them, to the information that you offer them. And, not much of, probing questions, if you will, but it's more going to be, okay, the fear of the outcome. That's what I see most in African-American patients. It's more of a question of, is this going to work for me? Is my outcome going to be similar to what I saw on the TV, on the ad, that this works for 60%, and things like that, versus, some of the, adverse effects, anything of that nature. One of the things that I've also noticed is when patients come in with a support system, with an advocate, maybe a family, their spouse, their children, a family member, it makes the discussion a bit more dynamic, because that person is able to listen more and not interact with you from the facet of fear. So, because when someone is behind the shadows of fear, you can't ask too many questions. You're just more of, okay, absorbing the information and thinking like, okay, what's going to happen to me down the line? So if at all possible, one recommendation that I would have for all patients, and mostly for African American patients, is to have somebody tag along with them for their physician visits, because that person can help diffuse the information, help ask the appropriate questions, and help them navigating the complex healthcare system that is, that they have to deal with.
So from what you've been saying, it sounds like enhancing, increasing, supporting health literacy, and probably not just in prostate cancer, but in everything, in the Black community is a critical sort of move that we all can make to defeat the barriers that racism presents to cancer patients. Does that make sense?
Yeah, I would say it's not the ultimate, but it's going to be one of the barriers that can change the direction and change the progression or projection of what our numbers are looking at like right now. Because the same way most people are very at least reasonably knowledgeable about diabetes, hypertension, there is still a discrepancy in health literacy in some of these disease states. But like you said, most people don't even know about prostate cancer until they have the disease itself. And even when we talk about the symptoms, right? Most patients, they could have been symptomatic for months and they will just sit on it because, they're just thinking, okay, what exactly is it, right? Versus someone that is knowledgeable about, oh, these are the symptoms of prostate cancer. Or this could be a symptom of prostate cancer. I bet I'd rather go get checked. I don't have to see it for 5 months, 6 months, because the longer the clock is ticking and cancer keeps growing.
Yeah, we had a talk by a witty fellow who said, my insurance policy is the take care of it next week policy. So well, you mentioned that health literacy is not the ultimate intervention we might consider. What do you feel is?
Well, other things that would impact this trajectory of prostate cancer disparity would also be clinical trial enrollment, clinical trial participation. So if we look at the numbers, which you're very familiar with, incidence and mortality, African Americans are heavily negatively impacted. But when we flip that coin and look at the number of African American men enrolled in clinical trials leading to treatment options, it's not the case. Sometimes you have 10%. Sometimes African American enrollment is not even mentioned at all. So it seems to me like if you want to address a disease that impacts a cohort, that either impacts a cohort, you want to pull those cohorts into the study, make sure they are overrepresented, if not equally represented. But till date, most of our trials don't even have it's not even close to equal representation. As a matter of fact, some of the trials do not even, in the publications, will not even disclose the proportion of racial representation in the trials. So if that aspect is missing, we cannot categorically say that a medication that was not tested in African American patients is expected to work for them in the same manner. So I hope it kind of makes sense what that what that trend would mean if we can at least strive and try to have equal representation and disclosure of racial inclusion in clinical trials, because that will ultimately guide clinical decisions. There are several, options regarding, prostate cancer treatment. But if we had enough racial representation, maybe it will be discovered that drug A works better for African Americans versus drug B. And as such, drug A will be the top line first option recommendation. And hopefully we can see a decline in the curve of mortality regarding prostate cancer. I mean, that is hypothetical, but that is also another action that we can take in oncology practice to help mitigate this gap.
Very good. While we have you, you're a pharmacist. What are the things that prostate cancer patients can do to sort of use you as a pharmacist to their best advantage?
Absolutely. So as a pharmacist, we have expertise in drug information, in drug knowledge. So my patients, I'm available to them to serve in regards to drug-drug interactions. So that's a big deal because patients, they don't have just cancer, they have diabetes, they have dyslipidemia, they have cardiac issues. So my service to the patient is not just focused on, oh, you're on Lupron and that's it, you're on apalutamide, you're on enzalutamide, and that's the only thing that I focus on. I also try to offer, drug interaction screening to make sure that, okay, the drug they are taking is not interacting with any other disease states that they might have, especially because several of the treatments in prostate cancer are oral medications. They are taking it at home. They are not, being seen in the clinic every single week or every time they're on their cycle, like an intravenous infusion. Right. So, drug-drug interaction is something that is one of the services that I love providing for my patient population. Another thing is also supportive care, because several of these oncology agents, medications comes with a wide array of adverse effects, toxicities. So how can the patient manage these toxicities, right? Especially for patients that are at home, they're on oral medications, ensuring that, okay, these toxicities is something that is manageable, that they can tolerate the effect of the drug, and if needed, consult with the physician to get some additional supportive care medications to help maintain a quality of life that, the patient will still be happy about. Or let's say a patient that has undergone prostatectomy, right? There could be concerns with erectile dysfunction. There could be concerns with, hormonal management and things of that nature. They're on Lupron, testosterone level, things of that nature. So I'm available to provide support for not just managing the disease itself, but the consequences or the ripple effect of the disease itself and the treatment that the disease offers.
Thank you for that. Dr. Ajewole, thank you very much for this helpful conversation, and I hope it sort of provokes action in those who are watching to sort of tell their friends and neighbors about prostate cancer, and the most simple manner of increasing health literacy in the community is just let folks know, like, I've got it and you might get it. And here's what to do about it. And notice I'm still alive, and chances are you'll still be alive too, even if you're diagnosed, because we're going to go through it together.
Exactly. Absolutely. Support system. It's very key. Thank you, Darryl.
Okay, thank you for being here in our conference. Thank you for being part of our faculty, and thank you for the good care that you give your patients, and for the research that you're doing, so that we can all learn more about what's going on in our prostate cancer world. So thank you for that.
Absolutely. Okay. Thank you, Darryl.
Okay.
My pleasure.